I've got sort of four main areas that I'm going to try and cover today. And a very, very brief touch on survivor history, which in another presentation, I would like to give a lot more space to, but I don't have the time today. I'll then look at what experiential knowledge is and what its value is, and then set it in the context of the sort of power and knowledge structures that surround us, really. And then with some conclusions and reflections. I'm going to watch the time. If I have got time, I'm going to touch on an example of a piece of an area of research and practice that is very close to my own heart, and a piece of work that I did a couple of years ago. So if I have got time, I will try and do that now. Just going to make sure I've got the time on my phone beside me here. So yes, that I seem to have included that twice, so that's good. That's got that rid of already. So language and terminology. First of all, just to touch on the language, and over the time that I've been involved in research, service user involvement, and so on, how the language has changed and how it still is very fluid, really, and yet in some places quite fixed. And I suppose it's quite important to sort of in another presentation, yes, presentation number 3, I would be doing something on the language and how the language has changed and what does that mean. But I guess it's just really important to remember that we call ourselves different things. Nobody, there's not a universal sort of agreement about what it is to be a person with lived experience, a service user, survivor. So yes, so I want to just very briefly touch on the importance of history and recognizing really some of the origins of that experiential knowledge that I'm going to be talking about, that mental health service users have been organizing for change for centuries. And at the same time, each of our individual stories matters very much. By listening to each other, we learn and build on our knowledge. And when we combine this knowledge, we create new understandings of our experiences. And if we build on that collective knowledge, we can share it with others for mutual benefit. And there's one example that I will perhaps come back to, of hearing voices, peer support, all of these and examples like that, which are interesting and very valuable, and also potentially co-opted, as experiential knowledge itself can be used, exploited, and co-opted. This is just one of my favorite slides, really. I just like to sort of use it as an example of sort of how the diversity and variety and madness of our histories, really. Just to sort of reference the fact that, there are people, knowledge production, I guess is the word, knowledge production in so many different ways. Activism is another form of, people coming together and collectively forming a knowledge that is useful, valuable, sharing and campaigning. It's not all about research. And just as Angie mentioned, Strategies for Living at the Mental Health Foundation, which was one of the threads of survivor research. There was also user-focused monitoring at the Centre for Mental Health. In 2001, Service User Research Enterprise, which is where Angie, Stan, and others have since worked as well. And Shaping Our Lives, which is another. There are many examples of around that sort of period of when sort of survivor research took up a sort of developed an identity, I guess. And I include Simba, Sharing Maudsley Black Action, because I remembered working with Premila Trivedi many years ago, and how the value really of people working together in and forming their own agenda, setting up their own agenda for involvement. If you won't agree with our sort of principles, then we're not going to get involved. And so those sorts of different kind of ways of developing knowledge and meaning making. It's so frustrating not to be able to talk about everything all at once. So I'm just going to now start to talk really about experiential knowledge and what we mean by experiential knowledge. Everything, I think, comes back to, starts with the value of telling our stories and listening to each other's stories. And one of my favorite readings on this is in a chapter in a book by Morgan and others. Narratives are important to all cultures. It's how we as human beings make sense of our lives, our identities, and our worlds. And then this is an article by Narani, who's somebody who, when I came across him when I was doing my PhD, I wished I'd written his article. You know, when you're sort of reading and, you know, coming to grips with other people's thinking about things, it was like, it was like a light bulb moment. But he's, again, saying the centrality of storytelling within those self-help support spaces enmeshes individual trajectories with understandings of similar ones, our own narratives sort of crisscrossing with each other's, and we rework our own narrative. Some years ago, I wrote a chapter in a book about a little bit about my own story. And I've since thought, you know, if I were to write that today, it would be very different. I mean, because that was about it was over 10 years ago that I wrote that one. And I think if I wrote it today, it would be a different narrative. And it's important that you know, to acknowledge that our narratives change and they develop and over time. So what is experiential knowledge? Is it just that individual story? I mean, whatever I say after this point, I definitely want to sort of value that individual story, all of our individual stories. But what is experiential knowledge? And there's a few different people's thoughts on it. The knowledge we've gained through lived experience of distress, trauma, illness, disability, service use, treatments, whatever that might be. Thomasina Borkman is one of the people who wrote about experiential knowledge first, I think, and I'm not going to make any great claims, but she is somebody who is referenced by many others. And she talks of it as specialized knowledge grounded in an individual's lived experience. It's strongly related for some people to the identity and positioning of the individual. So it's something about the context in which it develops as well. And it's developed through collective and sustained sharing between peers and is the result of personal reflective work. So there's something a bit more than just the original experience coming to the fore now. Borkman also talks about it being largely a pragmatic form of knowledge, holistic, a focus on the here and now. It's about how we live with those experiences or the impact of the experience or the distress. It is often a challenge to expert knowledge, not always, but often. And it needs to be shared or transferable if it's going to grow and be of value to others. This is something I just read this afternoon, okay? So somebody who's Danny Taggart, who gave a talk in Cork. It is simply different and necessary to reach the corners of madness that science can't reach. I thought that was rather lovely. So it enables us to make sense of our experiences and to develop a sense of belonging within communities of shared experience, perhaps. For some people, it's a more individual journey, a more individual project than that. But by socially and politically situating our experiences through interacting with the knowledge of others, we can gain a deeper understanding. But experiential knowledge can also be a resource for others to learn from and to share, a resource for social action, for coping with uncertainty. And it's certainly a resource drawn upon by peer support workers in their support of peers. So it's there, it's in the ether, I'm not really defining it at all. These are two people. I mean, Gorman writes, as we discover how particular experiences are mediated through social relations, we connect the immediate experience we started with to the larger social organization. In many ways, I think that encapsulates it for me. I think when we first have an experience of whatever nature that might be, and I think of myself in an acute ward in a hospital in North London, and coming to realize that my white skin and middle class accent had certain impact on my experiences in that hospital ward compared to the many Black people who were Black patients on the wards. And it's just then you start to put your own individual experience together with those of others and start to reflect on the political, social context in which we all survive or don't necessarily survive. So experiential expertise, seeking legitimacy for experiential knowledge. Where do we find the legitimacy for it? Because as I am going to come on to shortly, talk about the power context in which we work sometimes. So there's a positive granting, potentially there's a positive granting of authority to our peers based on mutual trust. So if we're meeting in service user groups, peer support groups, and we share knowledge, we share our own sort of expertise, we probably give each other a huge amount of authority. We trust each other's on the whole, we share knowledge of perhaps particular treatments, and we listen to other people's experiences, and we start to sort of learn something more about maybe local services, how to access benefits, some fairly pragmatic things, as well as the more in-depth nature of distress. Seeking legitimacy, if we're contesting the knowledge of the PSY professions, that could be a struggle to get legitimacy if we are actually challenging the knowledge that has the power. And the context of where we gain our experiential knowledge then is very important. Survivor research is a means of collectivizing experiential knowledge and perhaps gaining some authority, legitimacy, through bringing it together in a sort of rigorous or structured way. But still, nevertheless, experiential knowledge is dismissed within the context of medical knowledge. What is the status of the expert patient? What is the status of experts by experience? And being dismissed as lay knowledge is very common amongst that, in that context of medical clinical knowledge. And I guess, what I think is important is, coming to understand what's meant by valid, what's meant by knowledge. And I think I'll come back to that later on. I'm just giving here a very sort of conventional, a list of the sort of conventional ways in which experiential knowledge might enter research, might be given that opportunity to enter into the research field. Inclusive literature reviews, so literature reviews that don't just rely on the usual databases. So looking at including grey literature, blogs, websites, social media. I'm not going to mention consultation too much. Involvement, participation as advisors on boards, researchers, interviewers, co-production, working in partnership, and user survivor-led research, which is kind of where my heart lies, really, research that's led by people with lived experience. That's just a very brief list, and again, another potential complete presentation. So knowledge exists within a power, obviously power sort of context of power in this, where we can gain that legitimacy for experiential knowledge is a complex one. And I'm not going to pretend that I have read Foucault. I have read people who have read Foucault, so that's how I'm getting my quotation. But essentially, just to touch on the fact that when what society considers to be universally true about mental health is based on the knowledge of professionals and practitioners, not on the knowledge of those who live with the experience. The power to identify, name mental illness, to diagnose it, rests with the professionals and practitioners. And I think, you know, as many people have pointed out over the years, to be seen and to be understood as mad or mentally ill already potentially negates the perspective that you might share. So people are less likely to take your views seriously or believe them. So mental illness, mental distress is understood and classified in terms of symptoms. I'm not telling you anything that you don't know. It can be investigated scientifically. Progress in our understanding is made by new discoveries. That's the modernist sort of narrative about psychiatric knowledge. And you'll be very familiar, I'm sure, with the pyramid of evidence-based medicine, which puts editorials, expert opinion at the bottom. And where is the service user? Not even on there, really. So this power surrounds us all the time. Professional and clinical knowledge authority is legitimized by the social and cultural forces that affirm the value of science, objectivity, neutrality. And I think that's a kind of key thing about experiential knowledge, is that it is not objective and it is not neutral, but then neither is any other knowledge. And I think being dismissed as being subjective and biased, often experiential knowledge is made, if you like, put in this box of being on its own in that place of bias and subjectivity, where in actual fact, all knowledge is subject to a social and political context. But nevertheless, there are the decisions about what research is funded, decisions about what research is published, the peer-reviewed journals, decisions about what or if research influences practice, decisions about what happens in practice regardless of research, and even the agenda for meetings, what information is shared in advance of meetings. So it's from the small to the very much bigger. All of these areas are, on the whole, held by the professional and clinical knowledge bases. And I think it's really important to remember that when we, referring back to my slide about the different ways in which experiential knowledge might enter the research, the mental health research context, there are so many ways in which the decisions that are being made are not in the hands of the people bringing the experiential knowledge to the table. I don't know what the solution to this is. I hope you're not waiting for a solution at the end of the presentation. But what do we overlook if we ignore experiential knowledge? And Glasby and Beresford, writing in 2006, so quite a long time ago now, neglecting the views and experiences of people who use health and social care services gives a false and potentially dangerous view of the world. And when I read that to myself this afternoon, I thought, actually, I need an example of this. I need to say something about that. And I haven't really got enough time, but I'm going to tell you anyway a little bit about a project on self-harm. And so I obviously just going to do it very briefly. We did a survey, it was with the organisation Self-Injury Support, looking at people who had used their services and people who had not used their services, but asking people what they found helpful from services and what they were seeking. So 1/3 of those who made a comment about their experiences said that mental health services were unhelpful. People talked of having repeated assessments without support, of being passed from one service to another, and of receiving judgmental or punitive treatment. And a few had decided to avoid services altogether. A few had decided not to disclose their self-injury anymore due to fear of implications, future treatment, or involvement of social services. This, I think, is the danger of not listening to people with lived experience. What support have you found most unhelpful? The word that occurred most frequently across all of the questionnaires and interviews was judgment. What that people were seeking was not to be judged, non-judgmental responses. And what they had found unhelpful was judgment. And judgment is happening all the time for people who self-harm within mental health services. And this, over the years, people have sought to explain why they self-harm, to give an understanding of self-harm to others, to share their lived experience, and to try and influence services in a positive direction. And to be perfectly honest, what this piece of work demonstrated was that nothing really very much has changed since the early days of activism on self-harm, which was in the previous century. Voices of lived experience have not been heard. And people who are seeking people who listen and help them, and to help them understand, basically it's not really happening. People are actively avoiding services, but are continuing to self-harm. And people who get a diagnosis of borderline personality disorder only experience further discrimination within mental health services. And the little sort of spotlight of hope was in some generic services such as rape, well, when I say generic, rape crisis, not a mental health service specifically, and trauma-informed services were where some people were finding better help and hope. But essentially that was just to give you an example of where things are not, where people services, the system as a whole in a very big way is not listening to experiential knowledge of people who've been trying to share that knowledge for at least 20 years and probably 30 years, I think, and more, well, centuries. But intersectional issues and power. We mustn't forget the whiteness of research in general, just because power is in, you know, it influences us all in different ways to different extents. Not only is research largely white, but also user and survivor spaces, and versus the proportion of Black people, people of colour in mental health services as patients, service users, and also the sex, race and gender sort of profile of research. Who is the principal investigator? Who is the research assistant on short-term contracts? And I guess, you know, in your own departments, in your own projects, identifying the decision makers, who funds the research, where did their money come from, whose knowledge do they foreground, and what outcomes are they seeking? Whose knowledge do they foreground? Important. How do we integrate experiential knowledge within and through clinical practitioner knowledge and practice, given the power imbalances that persist? So what are my conclusions and reflections? I've read so many different sort of critiques of, you know, involvement. This is Nev Jones and others writing. Again, this is actually 20 years ago. I really need to update my references a bit more, don't I? But what they are talking about in this paper is the value of user survivor-led research that has the potential to generate new user survivor focused knowledge that will contribute to the transformation of mental health. And also they emphasize the importance of creating real and figurative spaces that promote collective meaning making among service users and survivors. They give the examples of conferences, user-run research initiatives, and other communities of practice. I mean, I would include all forms of service user groups, survivor activism, including online groups now, because of course people come together online more and more. And, you know, you would have examples like Recovery in the Bin and campaigns like Stop Sim and Stop Oxyvision, where you've got people coming together and sharing their experiential knowledge. And the recent work of the Stop Oxyvision and Stop Sim groups in particular have been just, I think, fantastically powerful in bringing together experiential knowledge with some degree, hopefully, of success. I mean, you know, we need to watch that space, I think. So a few conclusions and reflections here. Experiential knowledge has the potential to generate new knowledge and create more meaningful knowledge of use to people with lived and living experience. I think in a way I haven't said enough about the value of the knowledge, and I think the value of the experiential knowledge to those of us who share it with each other is considerable. It loses its value as it enters those academic research spaces. There is a need to encourage and support those spaces for experiential knowledge to grow and develop both within and beyond research, the collective meaning making. There is a need to redefine what constitutes valid knowledge, if only. There is a need to explore and challenge conventional research methods. Again, I mean, this is something that I haven't had enough time to say much about, but I think we need more creative research methods to bring together experiential knowledge in different ways. The deductive methods, deductive reasoning that predominate in many academic arenas are, and the qualitative, more sort of inductive reasoning that perhaps favors the exploration of experiential knowledge. Again, the status of one is greater than the status of the other. And I just think we need to think more creatively about how we bring these different approaches together. Another very recent writer here is saying, researchers and professionals need to develop the capacity to reflect on the sources and expressions of unequal relations of power and navigate them in partnership with patients. And that it would be great, actually, if it were to happen as well. I hope I don't sound too cynical. In the meantime, one option is to seek out alternative spaces where experiential knowledge is legitimized and valued. And so I do not work in the academic space for the most part. I work within voluntary sector organisations on the whole. This doesn't lead to a great deal of money or work a lot of the time, I must be honest. And I often find myself doing evaluations, but those evaluations will often value the knowledge that the people who are using those services are bringing to the table, because that's what they are for. And so I can put my own sort of experiential knowledge into that space too, alongside it. So, you know, it's an option. It's just not a very, it's not a very rich one. So that is one option. Or, of course, we continue the struggle to infiltrate, to bring that experiential knowledge into the table. I thank you for listening to me. I've got all the references on the slides if you're interested to follow any of those articles up. Thank you very much.